Hello, good morning. Merry Christmas. So I'm like Santa dropping down your chimney on Christmas morning. I didn't tell you I was going to show up today. Surprise. Um, so yeah, old guy, 8 o'clock in the morning, Christmas morning. There's nothing to do. Kids like Christmas, start Christmas at like 5 or 6 in the morning. Old guys, we start much later. So I thought I'd spend Christmas morning here with my extended family in the family courts. Um, just keeping consistent on Saturday morning, 8 o'clock. Coffee with Dr. Childress, or Santa, as the case may be. Today, I want to talk about the parenting practices rating scale. Um, and I may talk a little bit about your kids. I'm not sure if I'll get to that. Um, but this is a little gem of the solution that I haven't really addressed up until now. It's kind of slipped under the radar. Everybody's been focusing on, or I've been focusing on the shared delusion, factitious disorder, cross generational coalition, all the other stuff. Um, but now it's it's coming into play. I think the I work about 2 to 5 years ahead. And so this is from 2016, so it puts it 2021. COVID messed me up. I didn't anticipate losing a couple of years to COVID, but yeah. So I wanted to have this into the sort of the zeitgeist and ether surrounding family conflict by the time I reached this point. And just to explain a little bit, over the holidays here, I'll be working. I have 3 reports to churn out, which is why I've kind of gone silent on Facebook, is because I have to kind of stay focused on those reports and the forensic custody evaluations. And writing for me is difficult. It's a it's a process where I have to absorb all this information and process the information. It's hard work processing all that information through me to generate a concise and coherent narrative of the complexities involved in the situation. And so once I get into report writing, I kind of get locked into that place. And I've got 3 of them coming up, so I'm just going through line by line on the forensic evaluations. And that's tedious, but I have to do line by line because the ignorance is so dense and the information they miss is just sitting right there. And so what I do is go through line by line and extract the information that they just totally missed and then like discuss their problematic standards of practice relative to this. And the key issue, key issue, key issue is we need a proper risk assessment for possible child abuse to the differential diagnosis for each parent. And the 2 differential diagnoses are child abuse by the targeted rejected parent that's creating the child's attachment pathology towards that parent, or child psychological abuse and a shared persecutory delusion by the allied parent who is creating a false attachment pathology, a factitious disorder that's being imposed on the child, imposed on another. And so we either have child abuse from the targeted parent causing the child's attachment pathology towards that parent, or we have psychological child abuse, a shared persecutory delusion with the allied parent. And so all, all custody conflicts in the family courts, the very first thing that should happen is they should get bumped out for a proper risk assessment for possible child abuse to the appropriate differential diagnosis for each parent. And I'm just saying that in these reports over and over as I pull out the symptoms and say, there needs to be a proper risk assessment to this differential diagnosis because, look, there's all these symptoms of a potential persecutory delusion here. And there's no indications of child abuse by the allied parent. And it's that piece, no child abuse by the allied parent, that the parent child or parenting practices rating scale is designed to address, because this pathology wants to keep things vague and undefined, because then it can make these allegations and continue in things in conflict and say false stuff, and nobody can get a handle on anything. There's no reality, no ground we can stand on. And so the forensic psychologists were created by the pathology and do exactly that. They don't diagnose and they don't treat anything, but not diagnosing what the pathology is just plays right into the pathology's hands. They're not identifying the shared persecutory delusion. And that's a problem, because if you believe the shared delusion, you become part of the shared delusion. You become part of the pathology. When the pathology is child abuse, you become part of the child abuse. So all the forensic psychologists who are missing the diagnosis, misdiagnosing the shared delusion, are becoming part of the child abuse. They're becoming child abusers. They're failing in their duty to protect the child, and failing in the duty to protect the spouse from spousal abuse. So that's becoming more and more into focus, at least wherever I am. And I'm in the family courts now reviewing custody evaluations one by one by one, line by line by line. And that's the fundamental issue. We need a differential diagnosis. So let me explain a little bit. I'm going to suggest that all of you parents, all the targeted parents, start asking your involved mental health people to identify what's the problem with you. Okay, this is for you. This is a parenting practices rating scale where the involved mental health professional rates your parenting. So that's that half of the differential diagnosis, that the targeted allied or the targeted rejected parent is somehow abusing the child. Well, this is going to address that. Okay. The other half, the shared persecutory delusion, is addressed with a mental status exam of thought and perception if they want to get hard nosed with me, or they can listen to me and it's the diagnostic checklist for pathogenic parenting, 12 associated clinical signs. So they can either go the easy route or they can do a mental status exam of thought and perception. Up to them what they want to do, but it's a shared persecutory delusion that needs to be properly assessed and accurately diagnosed. So for you, let me just explain the structure of what I did here. Psychologists are trained to develop assessment measures. That's our job. That's what we do. I've got classes, psychometrics of assessment, all this sort of stuff. We are trained to do that. I have taught the classes at the graduate level in psychometrics of assessment. I know how to construct the assessment instruments. So what this is essentially two categories: whether the targeted parent is abusive range or whether they are normal range, because that's all we need to decide on the differential diagnosis. If the targeted parent is abusive range, then that becomes the focus of treatment, not a persecutory delusion. That parent's abusive, and we need to address that. Okay. If the targeted parent is normal range, then they cannot be producing the attachment pathology in the child. Problematic normal parents produce insecure attachment that more strongly motivates the child to bond to the parent. So normal range parents do not produce severe attachment pathology that the child wants to get rid of this parent. And so we need that documented clearly, for the courts, for mental health people, for all the treatment providers, for everybody involved. What is the problem with the targeted parent's parenting, if there is one? And if there's not one, we need to get that documented into the record so that we can move on to assessing the delusional disorder. If you do not assess for the truth or falseness of the allegation, you cannot possibly diagnose a delusion. Okay, that's impossible. So the shared persecutory delusion of election fraud, the big lie, okay, If we cannot verify that there was no election fraud, then we cannot um, identify the shared delusional disorder, the big lie. So the first thing we have to do is go through all the courts, all the legal challenges to the votings and all this stuff, and get documentation from the courts that there was no election fraud in 2020. Then we can diagnose that it's a big lie and the persecutory delusion. So it's the same process here. There's allegations that you, the targeted parent, are somehow abusing your child. So is that true or false? Let's find out. So ask your involved mental health professional to fill this out. And it's not some sort of um, you know, validated measures. It's their personal opinion or professional opinion. So they interview you, they go through all the allegations, they talk to everybody involved, and they determine, based on their clinical judgment, what is your parenting like? Is it abusive range or is it normal range? Now, to improve the reliability of this measure, I've actually broken it into 4 categories. 2 categories go one way, 2 categories go the other way. That improves the reliability of the measure when you start getting greater information and then you collapse it into its categories. It stabilizes the measure. And then I did something even more to get reliability. Each of the 4 levels, I identified specific problems in each one of those levels. So you can identify specifically what is the problem with the targeted parent. And then we collapse that into its level. Then we collapse the level into either normal range or abusive range, which is what we're looking for. So this is a highly reliable level. It's just based on clinical judgment of the person, of the mental health person involved. So just ask them, what's your clinical judgment of my parenting? Which level am I in? And so let me explain the 4 levels here. Level 1, first page, is abuse, child abuse. So we have clear child abuse by the targeted rejected parent. Sex abuse, physical abuse, neglect, psychological abuse, and it's been identified, sort of diagnosed. Everybody's clear on that. Now, under each of these, you can see that under, let's say, there's 2 additional categories. There it is. Okay, so it's an allegation. So the person, right? There's an allegation of sex abuse, but it's neither confirmed or disconfirmed, or there's an allegation that was deemed unfounded. And in which case they wouldn't check that there's no sex abuse, but there's an allegation of sex abuse because that speaks to the persecutory delusion. Same thing with physical abuse. There you can check, yes, there is physical abuse, or no, there's not physical abuse. The box isn't checked, but there's allegations of physical abuse, neither confirmed nor disconfirmed or unfounded. And so that gives us information that we'll be using later, potentially relative to the persecutory delusion. So it goes through sex abuse, physical abuse, emotional abuse, psychological abuse, neglect, and domestic violence exposure. And so that's level 1. If the targeted parent is determined to be abusive of the child, that's the focus of treatment. Everything else stops. Now, page 2 is the other categories of parenting. So level 2 is just under abusive. We can't say it's abusive, but boy, it's bad parenting. It's either very hostile, aggressive parenting, or very lax and neglectful parenting, or very intrusive, controlling parenting. Something. It's really bad and severe. So I have overly strict discipline, overly hostile parenting, overly disengaged parenting, overly involved intrusive parenting, or family context of high interspousal conflict. And so so level 2 is really serious pathology. Levels 1 and 2 would be abusive range parenting, which we would put the targeted parents' problematic parenting on a treatment plan, identify goals and what the behaviors are, that the parenting behaviors are that are problematic, put them on a treatment plan, fix them, and then that should resolve the attachment pathology of the child because we now have a normal range parent. That's what we do. We fix things. The pathology, and it goes twisty on this because it says the resolution or the remedy for problematic parenting with the targeted parent is to eliminate that parent. No, 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 that's causing attachment pathology, severe. The remedy is you treat it and you fix it and you restore the child's attachment bond to that parent. That's what you do. Okay, so um, it's just fundamentally wrong. The pathology's thinking is about therapy, and what we do is fundamentally wrong. So I'll get in there as a clinical psychologist and correct some of these um, flying monkey kind of people, professionals out there, about what we do with abusive parenting. We fix it and then we restore with the child. I was working foster care. That's what we do all the time. Is got a physically abusive parent, you separate the child, protect the child, then you fix the parent's parenting, then you restore the attachment bond to the formerly abusive parent with enough safeguards in place to make sure the abuse doesn't resume. So levels 1 and level 2 are severely problematic parenting. Okay. Now, for you targeted parents, you guys aren't in these categories, either one of those categories. You're in levels 3 and 4, most likely in 4, but maybe in 3. So 3 is normal range problematic parenting. So we have severely problematic parenting, level 2, and then we have normal range problematic parenting. No one's perfect. Parents get a little grumpy, hostile. They were raised in their own family of origin things. They may handle things somewhat inappropriately, and we would encourage them to handle things differently, but it's not abusive range parenting. Some of that might be cultural. Okay, so let's say Japanese culture is more shame based and socially organized, and has respect, proper hierarchy, respect, and uses shame a lot. Now, in our Western culture, we may not like that approach to parenting, but it's not abusive range parenting, and it produces relatively healthy Japanese. And so that's just a cultural issue. I know some Hispanic families tend to be a little bit more lax in some of their parenting, or allow older children to kind of these are normal range problematic, but it's in the absence of child abuse, parents have the right to parent according to their cultural values, their personal values, and their religious values, and that's a broad range. So the only question we're interested in really is whether or not they're an abusive parent. If they're not abusive, then if they're problematic, normal range problematic, then they're not causing the child's attachment pathology. A normal range problematic parent will produce an insecure attachment that more strongly motivates the child to bond to the problematic parent. So that cannot produce severe attachment pathology of the child seeking to uh, sever the parent-child bond. So level 3 cannot produce the pathology, and we just put it on a treatment plan, fix it, and everything's fine. The most of you though are in level 4, and that's positive parenting. And there's 3 categories of that. One is sort of a little bit more positive parenting, but a little bit more on the structure and rule oriented approach, discipline approach. It's totally fine and positive and great, but there's like rules in the family and authority kind of stuff going on. And then the other side of that is a little bit more flexible, negotiating, a little bit more lax, permissive in their parenting approach, but they're still positive and healthy. So one tends to use more of a discipline strategies, the other tends to use more guidance strategies. And then there's in the middle, the healthy normal range parents that kind of use both flexibly. Sometimes they're a little bit on the structure side, sometimes they're a little bit on the negotiation side. And so all of that's normal range, all of that's healthy. Um, and so we want the involved mental health professional to document where you are on this. Now, if some other mental health professional disagrees and says, no, 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 because I was, individual therapist, I was talking to the child, I think that the targeted parent is abusing the child. Have them document. What do you think is is the problem? Where do you put the problem? And then why? We can have, why do you say this parent is severely problematic, and why do you say they're normal range and healthy? What are the specifics that support your diagnosis of the parenting practices of the targeted parent? Words. We must first diagnose what the pathology is before we know how to treat it. We must first identify what the problem is before we know how to fix it. So diagnosis, identify, pathology is problem, treatment is fix it. So we want to identify what the parenting practices, clearly identify what the parenting practices of the targeted rejected parent are. Are they abusive range level 1 and 2, or are they normal range 3 and 4? In addition, now the third page I just kind of added on just because I'm collecting information and it's useful information. So the third page just has 3 scales associated with it. Again, rating scales. Classically, these are called SUDS. For the first one, it's like, you go into the doctor and you say, this hurts, and the doctor says, on a scale of 1 to 10, how bad is the pain? Okay, that's not a validated measure or anything. That's just on a scale of 1 to 10, how bad is the pain? And so the first one has to do with permissive to authoritarian. So that, and I put it on 100 range, 100 points. Instead of 1 to 10, it's 1 to 100. It gives more flexibility in the rating of permissive on one side, authoritarian, or what do you call it? Yeah, authoritarian discipline on the other. So in normal range is in the mid range. Okay, so that'd be 40 to 60, and you can expand it out 30 to 70. So anywhere in the 30 to 70 range, whether you tend to be more lax and permissive or more authoritarian, that's all normal range. When you get to the extremes, and where I put the extremes are at the 10 points, 0 to 10 on the abusive neglect, and 90 to 100 on the hostile abuse. When you get to the extremes of an authoritarian parent, you get into the hostile parenting abuse. When you get into the extremes of the lax and permissive parent, you get the abusive, neglectful parent. So that's 0 to 10, 90 to 100. If they're in the 20s, or teens or 20s, that's normal, but you're a little worried about them. There's going to be some higher degree of conflict in the family, one way or the other. Either, that's 20 or teens or 20 would be permissive parenting that you'd like to see some additional supervision of the child. Maybe regarding the internet or drugs or sex or something. You want to see greater parental involvement, but it's still normal range. And then in the 80s, that's pretty rule bound and inflexible and authoritarian. So you'd like to see that parent become more flexible, a little bit more empathy for the child, a little bit more negotiation, but it's not abusive range yet. But it's of concern. So 80, 90, 0 to 10 to 20, both of those are in the concern range. But anything in the middle, just where does that parent fall? Based on the clinical judgment of the involved mental health professional. Just document. And this is a secondary documentation that you as a targeted parent are a normal range parent. And that whether you're a little rule bound or a little permissive is still normal range. The next one I thought an interesting measure is to look at, because I want to encourage, I got the mental health professionals' attention. I say assess for the empathy, the empathic capability of the parent. Are they able to empathize with the child or with other people? Do they have the capacity for empathy? Because narcissistic and borderline personality pathology won't have that. Narcissist is just flat out blank, and the absence of empathy is the capacity for cruelty. And so you can assess either way. You can assess their empathy directly, or you can assess the capacity for cruelty. The And so that's the narcissistic side. The borderline is so disorganized, they have what's called projective identification. They project their own stuff into the child as if, and then identify with it in the child and say, oh, I have a perfectly wonderful empathy with the child. No, they don't. They're having empathy with themselves. They've obliterated the child, and there's only one person present. And so that's the two variants, the narcissistic absence of empathy or the borderline overwhelming absence of empathy. And so on one side, you start with the narcissistic spectrum is at a 1, the borderline spectrum is at a 5. And so normal range is 3, and then you maybe have a normal range a little bit, on the absence of empathy side, a little bit on the little arrogant, grandiose side, that'd be a 2. You might have normal range a little bit on the over-involved side, that would be a 4, or anything in between on this scale. And so this is a 5-point Likert scale, and with 3 being normal range, and then 2 and 4 kind of normal, a little bit different, and then 1 and 5 would be of significant concern. So let's get a rating on what they think about that. And if they say you can improve your empathy, well, then let's put that on a treatment plan and improve your empathy and help you do that. If they say, you're a little too over-involved, then let's help you develop boundaries, psychological boundaries, and work on that. But let's specifically identify what the problem is and fix it, because there's no problem. And the targeted parenting is totally normal, fine parenting. And we need the mental health people to step up and start documenting that for the court, for the other mental health people, for the other parent, for everybody. And then if somebody disagrees, we have specifics about why they disagree, and let's start talking the support for their opinion. Give me specific examples that support your judgment. The final one that I put was just because there's potential issues involved in parenting that can be a factor, a consideration. And so there's parental schizophrenia spectrum issues, parents, psychotic in some degree. And then not only that would be clinical concern 1, but not only is that a clinical concern, but also under that I have whether or not it's stabilized on medication, yes, no, or variable. Because if we have a schizophrenic parent who's stable on medication, we're good. I'm good. Parents have the right to be parents, and if they're fragile, we medicate them, we help them, we give them the support they need, but we don't take their kids away. And so, as long as they're getting treatment for them. And then the number 2 is parental bipolar spectrum issues. So now we have mood instability, a little manic, a little depressed kind of stuff, and then is it stabilized on medication? If it's stabilized on medication, I'm good. There's no problem with that. If it's unstable, if the parent's unstable and they're not getting medication for the treatment of the bipolar disorder, then they're going to be a problematic parent because they're very erratic in their behavior and perceptions. Number 3 is parental major depression spectrum issues, including suicidality. Parental depression is devastating to the child, okay, and it's one of the hidden devastations of child development is parental depression, and so that's a significant issue. But again, if the depression's under treatment and is getting treatment, then it becomes not a problem. So stabilized by treatment, yes, no, variable. It doesn't necessarily need to be medication. Medication's only variably effective with depression. But if the parent's getting treatment, we're good. Parents have the right to be parents, and they have the right to have children. Parental sub excuse me, parental substance abuse issues. Obviously, those can affect parenting. So a parent can be a wonderful parent, but they're a meth addict. Oh my goodness, no, you got problems we need to address. But now under that, I have treated and in remission for 1 year. Then I'm not worried about it. So if there's a history of alcohol use and stuff, or a history of drug use, yes, we note that. We're attending to that. We want to pay attention for relapse. But if the parent is clean and sober for a year, they're good. Okay. They can have a child and be with the child. The issue there of concern is child neglect and child endangerment. If the parent's passed out, is that child neglect? Or if the parent's driving drunk or something, that could be child endangerment. The next one is parental narcissistic or borderline personality disorder traits. And so that speaks to everything else we're looking at. But I want the mental health professional to, if there's narcissistic or borderline, not personality disorder, personality traits. So the borderline tends to be a little bit more emotional, lack of boundaries, invalidating environment. Narcissist tends to be a little bit more absence of empathy, self-absorbed. It's all about them. Those both can be problematic parents. But then I also have under that in treatment. So if I have a borderline mom who's in dialectic behavior therapy, I'm good. Again, as long as there's no child abuse to the child, then parents have the right to be a parent. And so, if mom has borderline personality pathology, DBT, and we're good to go. Let's help and treat whatever the issue is. Narcissistic pathology is interesting because they don't go to treatment. So good luck getting them into treatment. If they're in treatment, great, but they don't like treatment at all. So that's their challenge. And then parental history of trauma, because that's the unresolved trauma that gets passed on from the parent to the child. But again, treated or is in treatment. Yes, no, variable. If they have past trauma and they've gotten treatment for it or are in treatment for it, I'm good to go. If they haven't gotten treatment for it, then it's most likely affecting their internal working models, their schemas for how they interpret situations. So they're going to be a problematic parent. So that's what this scale is, parenting practices rating scale. It's for the targeted parent. Don't rate the allied parent. It doesn't matter. That's not the issue with them. We just want to document and vet that the targeted parent is normal range. Once we do that, we can then shift over to the persecutory delusion with the child, or with the allied parent, and then shared by the child. The definition of a persecutory delusion from the American Psychiatric Association. This is the criteria, like a legal statute with clause and the wording and stuff. The persecutory type are delusions that the person or someone to whom the person is close is being malevolently treated in some way. And you Google malevolent, it's having or showing a wish to do evil to others. So a persecutory type is a delusion. What's a delusion? A delusion is a category is a thought disorder. That's the broad category, a thought disorder. The type of thought disorder is a delusion. A delusion is a fixed and false belief maintained despite contrary evidence. So first off, the allied parent, do they have a fixed and false belief that's maintained despite contrary evidence? I've got two criteria there. That the person, them, or someone to whom the person is close, their child, is being malevolently treated in some way. So a fixed and false belief that their child is being malevolently treated in some way. That would meet criteria for a persecutory type of delusion. The assessment for a delusional thought disorder is called a mental status exam of thought and perception. It's a very structured type of clinical interview where you you sweep the frontal lobe executive function systems for linear logical reasoning. And what you get with a thought disorder is it's not linear logical reasoning. A thought disorder, a delusion, starts with the conclusion as fixed and then constructs the evidence to match the fixed belief. The rest of us follow the evidence to reach our conclusions, but a delusion goes the other way around. It starts with the conclusion as fixed and then constructs the evidence. So again, the big lie, the election fraud issue. They start with the conclusion as fixed. Trump won, so therefore there must be election fraud. And then they try to go and create the evidence to match their fault. But there's no there. There is no evidence because they're not following the evidence to their conclusion. The conclusion starts the whole thing. And so what a mental status exam does is it kind of systematically runs linear question lines through their frontal lobe executive function systems to see if they can support their conclusions based on some degree of evidence. Now, we're not assessing what their conclusions are, we're assessing how they reach those conclusions. Do they follow evidence to reach the conclusion, or is the evidence irrelevant, constructed sort of after the fact? And in addition, that criteria of maintained despite contrary evidence, when you present a delusion with contrary evidence, it doesn't affect the belief system. And so you can watch that as you're doing the mental status exam, as they have this belief, this fixed belief, false belief, and you present contrary evidence to that belief. Do they incorporate that evidence into their thinking and conclusions, or does it just bounce off and fall to the floor? So that it's a very structured approach. And I would recommend, want to know more, Google mental status exam and go down to the NCBI entry. That's from the National Institute of Health. And they do there's a chapter 207 from this guy on the mental status exam, 207 of clinical methods, mental status exam. He talks about all the different mental status exams: language, memory, mood and affect, and one for thought and perception. And, are they realistic fears, or are they exaggerated responses with no discernible basis in reality? And so that's what it's designed to assess for, the mental status exam. And the third paragraph on that indicates that it's one of the hardest mental status exams to give and requires considerable experience to do. And that's true. I was trained for 12 years in the mental status exam and the diagnostic assessment of delusional thought disorders to 90% reliability, to the head of both heads of the diagnostic unit at the Brentwood UCLA VA, who are also the authors of the brief psychiatric rating scale, the oldest, most widely used scale to measure psychotic symptoms. So for 12 years, I was trained in the mental status exam of thought and perception. Now, the issue is a possible persecutory delusion. The assessment is a mental status exam of thought and perception. None of the forensic psychologists here, very few of the clinical psychologists know how to do a mental status exam of thought and perception, because most of the time people who know that are treating schizophrenia spectrum issues. They're not working the family courts or normal range stuff. So you can find a clinician who knows how to assess for delusional thought disorder. However, they're going to be a clinician working with schizophrenic patients or maybe bipolar patients, not the family courts, not narcissistic borderline pathology, not family systems issues, not attachment pathology. So they're going to be totally out of the water in all the other domains, but they will be able to assess for persecutory delusion. I've already contacted Joseph Ventura, Dr. Ventura, who I trained with for 12 years at UCLA. And he's still at UCLA Neuropsychiatric Institute, and he's one of the authors of the brief psychiatric rating scale. Item number 11 is unusual thought content. That's the item number, 7 point scale. You can rate the delusional thought disorder. And so I've already kind of alerted him that because he trains in the BPRS, that's what he does out of UCLA. So I alerted him that he might be getting contacted by people in the family courts around assessing delusional thought disorders. Um, just so in case it happens, he's not caught off guard. But I would recommend consistently all the time that a brief psychiatric rating scale, BPRS, be conducted with these children, specifically, on items for like anger and suspiciousness and depression and anxiety and unusual thought content. There's 24 items total. You don't need to diagnose or assess all 24, but the ones you need. So unusual thought content. When I apply the BPRS to the pathology in the family courts and the child's pathology, my rating's about a 5, which is moderately severe persecutory delusion, because the criteria for, the criteria, one of the important criteria is full conviction. Does the person have full conviction in the false belief? And the operational definition in the BPRS for that is that they have acted as if the false belief was true. So in the family courts, yes, the person has acted, the child has acted as if the false belief that they're being malevolently treated in some way, they have acted as if that's true. They're refusing to go with the parent, and they're making allegations and stuff. So, so that's, and the cutoff, if there's full conviction, then it's at least a rating of 4. And that's the difference. A 1, 2, or 3 is normal range. It's kind of unusual thought, but it's normal range unusual. 4 is pathological. Now we have a delusion. A 4 would be an encapsulated delusion. It's very localized, very focused, which this is. It's an encapsulated persecutory delusion towards one person, the parent. So it's an encapsulated. And there's no functional impairment. So for a rating of 4, but the child has functional impairment in the family, sometimes even in school, but at least in the family is severe functional impairment. So it's not a rating of 4 because it has functional impairment. So then you go to 5, and that's full conviction with functional impairment. Yep, that matches. So my rating of unusual thought content on the BPRS for the pathology in the family courts is about a 5, moderately severe. Then you look at preoccupation and functional impairment. If the child's highly preoccupied, it can go up to a 6, severe, or even if they're getting hospitalized, psychiatric hospitalization, get up to a 7. So I would recommend standard of practice every single time that you got attachment pathology in family courts surrounding child custody, bump it out to get a proper risk assessment for possible child abuse to the differential diagnosis. Is there a shared persecutory delusion? Rate the child's symptoms on item 11 of the BPRS, also on a couple of additional ones: anger, depression, anxiety, suspiciousness. Would probably be the key ones. Just get a 1 to 7 rating on it. Let's document what the child's symptoms are. So, but because nobody knows how to do the mental status exam over here, in the family courts, or any people that will be coming in from clinical psychology, most likely, I have provided a little scaffolding help for the mental health people, because I know how to do it. I know how to diagnose delusional thought disorders. I know what this pathology is. I've described it in detail in my book, Foundation. So I'm providing a little help for them, which is the diagnostic checklist for pathogenic parenting. And there's basically 3 symptoms. They're based on John Bowlby's 3 volumes: attachment, protest behavior, separation and loss, which is the persecutory delusion is coming off of the loss. The inability to process grief is kind of twisting up their perceptions of the situation. The first, symptom number one, and each one of these is diagnosable in and of itself. So I can make the diagnosis based on any one of these three symptoms because all three of them are impossible symptoms. They never show up anywhere. And yet, they will be present with this court involved custody conflict um, because it's a shared delusional disorder and factitious disorder imposed on another. The first one is attachment pathology towards a normal range child. Now, with this instrument, the diagnostic checklist, I provided all sorts of operational definitions because it's a good research measure. It's a good way of identifying the population, an operational definition for the pathology for research purposes, and also by providing a clear professional definition improves the reliability of the ratings. So it kind of got technical language there, but it's basically is a child rejecting a parent, a normal range parent. And that normal range goes back to this. See how that plays in there? So the parent is a normal range parent. So then symptom one is a child rejecting a normal range parent. That puts it in the category of attachment pathology, which means it's being caused by one parent or the other. It's not coming from the child. Somehow one or the other parent is causing the pathology. That's the only thing that causes attachment pathology. And it's towards a normal range parent, which is impossible. A child never rejects a normal range parent. They might, no, they don't, but they might reject an abusive parent. But this parent's not abusive; they're normal range. So no, that's an impossible symptom because that's not how the attachment system works. Um, but I didn't want to just make it a single symptom diagnosis for these mental health people because that puts too much pressure on them. So is that the first symptom? And you don't have to use the checklist even. You can just write it on a napkin, just ask them, is the child rejecting a normal range parent? Am I a normal range parent? And is the child rejecting me? Boom, there's one. Number two, the second symptom actually has two symptoms, two possibilities, two variants of the second symptom. The second symptom is excessive protest. And John Bowlby's book on separation, volume 2, talks about anger and anxiety as the two protest behaviors. So how do we define excessive anger? I've operationally defined it as 5 specific narcissistic symptoms in the child. Um, Absence of empathy, grandiosity, judging the parent, entitlement, haughty and arrogant attitude, and splitting. Splitting and absence of empathy are very characteristic of narcissistic personality pathology. You never see them in a child. You only see it in personality pathology. Now, that too is an impossible symptom in a child. The reason? Because narcissistic personality pathology is an adult pathology. It's not a child pathology. During childhood, it's an attachment. It's insecure attachment, insecure disorganized, and with avoidant features, or insecure disorganized with ambivalent features. But it's an attachment pathology in childhood. But then in late adolescence and early adulthood, the brain kind of crystallizes up its personality structures and takes those attachment system internal working models, and they begin to guide perceptions of things and become personality pathology. And so you don't see a 12-year-old with narcissistic personality disorder. No, you never see that. You see them with attachment pathology at 12. So high anger would be the narcissistic symptoms. The child's judgmental, the cruel, absence of empathy, haughty and arrogant attitude, sense of entitlement, and splitting, all good, all bad, and a rigidity in beliefs. Things will never change. That's the splitting symptom. Or sometimes, especially with the younger children, 4 or 5-year-old child, they don't have enough personality structure yet to acquire that symptom of personality pathology. What it looks like in younger children is high anxiety. The child displays extremely high anxiety about being with the targeted parent, often displayed at the exchange points. So the child won't get out of the car and is crying and doesn't want to leave the allied parent. But then once the exchange is met, about 45 minutes, an hour later, the child calms down and is fine with the targeted parent and has a totally fine visitation, but it's just such anxiety surrounding the child. And the operational definition for that variant, the high anxiety protest, is the child will meet DSM-5 criteria for a specific phobia towards the parent. Avoidance, panic attacks, preoccupation kind of thing. And but that's also an impossible symptom. That's a child has a mother phobia or a father phobia. If that's true, that's the first case ever. We should write it up for the journals. The child develops a mother phobia or a father phobia. Never happens because the attachment system won't allow that. There's predators out there to eat the kid. If the child develops a phobia for the parent, the predator's going to eat them or they're going to starve or something. So all genes that would allow for a phobia towards a parent have been removed, and the attachment system strongly motivates bonding. Now, sometimes with older children, 12, 14 or something, you'll get a mixed blend. You'll have the 5 narcissistic symptoms, so they're on the high anger display, but they'll also claim to be afraid of the targeted parent. Now, that's, again, not realistic. First off, the narcissistic personality disorder, but children who are authentically afraid of a parent become submissive, not assertive. A child who is afraid of a parent does not assert into that parent because that's a dangerous parent. And yet these children are saying, I don't want to be with that parent. And they're rude and they're hostile, rejecting, cruel. No, that child is not afraid of that parent. So that when the child starts to say, yeah, and I'm afraid, no, you're not. Where the fear is coming from in both variants is the persecutory delusion. It's the allied parent who has the activated attachment insecurity, who's afraid, malevolent treatment somewhere out there. And when the parent becomes afraid or signals anxiety, the child activates the child's attachment system to stay close, because the attachment system developed out in the savannas with predators, and the parents are looking out for predators, and child feels safe. And so it's a predator driven system. If the parent all of a sudden goes, I see something scary, the child goes, what is that, and gets close to the parent. So this parent is going, I see something scary, and the child goes, what is it? And he says, the other parent. And he goes, oh my goodness, you're the predator. And they just all mess up with that. So you see the high anxiety display. The third symptom on the diagnostic checklist is a persecutory delusion in the child. So does a child have a fixed and false belief that they are being malevolently treated in some way? If the child has, and that's impossible in a child, the child doesn't develop a persecutory delusion towards a normal range parent. It doesn't happen. So if that symptom's also present, we got persecutory delusion, we have narcissistic symptoms or child phobia, and the child rejecting a normal range parent, there is only one explanation for that, which is the pathology I describe in Foundations, a factitious disorder imposed on another, a shared persecutory delusion created by a narcissistic, borderline dark personality parent. And so those two instruments are designed to go together. The diagnostic checklist is an aid to the ignorant mental health people. If they don't want to use it, well then fine, do a mental status exam of thought and perception. But we need a diagnosis. Is there a shared persecutory delusion? Diagnosis guides treatment. The treatment for cancer is different than the treatment for diabetes. The treatment for authentic child abuse by the targeted parent is different than the treatment of a shared persecutory delusion by the allied parent. So which is it? We need an answer to that question. If your mental health professional says, I don't diagnose pathology, then they're pretty irrelevant, aren't they? Because that's what we need. We need a proper assessment an accurate diagnosis. Is there a shared persecutory delusion present? And all your GALs and minors councils and lawyer-like people should be ensuring that the child gets a proper assessment and accurate diagnosis that leads to an effective treatment plan. Lawyers don't diagnose pathology, so let's get it out to a psychologist and get back a diagnosis whether there's a shared persecutory delusion in the child. Because when possible child abuse is a considered diagnosis, our diagnosis has to be accurate 100% of the time, because the consequences for the child of misdiagnosing child abuse are too severe. And so we need to do a proper risk assessment for possible child abuse to the appropriate differential diagnosis for each parent. Is the targeted parent abusive, or is there a shared persecutory delusion? If you believe a shared delusion, you become part of the shared delusion. You become part of the pathology. When the pathology is child abuse, you become part of the child abuse. So it's really important for judges to get a diagnosis of whether there's a persecutory delusion before they start making decisions about which parent the child should go with, because they could be leaving the child or sending the child to an abusive parent and restricting the child's involvement with a normal range parent. Same for the mental health people. You're individual therapists, you're treating something. What are you treating, cancer or diabetes? Because if you're treating cancer with insulin, the patient's going to die from the misdiagnosed and mistreated cancer. As an individual therapist, is this a persecutory delusion? Did you conduct a proper risk assessment for possible child abuse? Did you conduct a mental status exam of thought and perception for a possible delusion? So I'm just hammering these forensic people and the mental health people on what's your diagnosis, because diagnosis guides treatment, and they've misdiagnosed the pathology. So, and anyone who doesn't, any mental health professional who doesn't put a diagnosis is in trouble, because they are asserting for a fact that they have verified that there is no diagnosable child abuse, because they didn't even put it by rule out. They didn't even say it was a possibility. So, because if there was child abuse, they would tell the court, right? If there was a persecutory delusion, shared they would tell the court. They didn't tell the court, so therefore they're asserting there's none present. And my little sentence or description when I reach that point and that they haven't diagnosed the pathology is that mental health professional, the question is whether they've misdiagnosed the pathology, but we can't determine that because they would first have to give a diagnosis before they could misdiagnose something. So they are actually practicing below the level of misdiagnosis. They would need to improve their standards of practice to reach misdiagnosis. We're not even talking accurate diagnosis. Just to get out to a level of misdiagnosis, they would have to improve and give a diagnosis so we could decide whether it's a misdiagnosis. The way diagnosis works, you give your diagnosis, then you offer the supporting symptoms that meet the criteria for that diagnosis. So give a diagnosis and then why? And, is it ADHD or autism? Well, what are the symptoms? And let's put them into the various boxes and see which way. Is this authentic abuse by the targeted parent? If so, tell me exactly what's the problem. Give me the level. Give me what the behaviors are that we're going to put on the treatment plan. Document it. Or is it a persecutory delusion in the alive parent that's being imposed on a child? A shared persecutory delusion, a false attachment pathology, factitious disorder imposed on the child, imposed on another, for secondary gain of manipulating the court's decisions about child custody and to meet the pathological parent's own emotional and psychological needs. So with that, I'm going to run away to my Christmas. Happy Christmas, everybody. I'll talk to you about your kids next time. Fundamentally about your kids, they're lost. They're fine, but they're lost. Don't hold them like responsible for what they're saying, and don't believe what they're saying. Holy cow! No, they're lost. They're confused. They love you, gangbusters, but they're processing grief in a funny way, grief and sadness, because the pathological parent processes grief, sadness in a funny way. That's the Kernberg quote. I'll post that up later to my Facebook page about how the narcissist um, doesn't process mournful longing, the emotion of sadness, mournful longing, and instead converts it into anger and resentment loaded with revengeful wishes. That's how sadness is expressed by the narcissist. So they just get the child to respond in the same way to the child's sadness, that they process their sadness as anger and resentment loaded with revengeful wishes because they blame you for whatever. It's all coming from the allied parent, psychological control, enmeshment with the child, boundary violations, stuff like that. So I'll talk more about your kids next time, but don't they're fine, they're lost, they're confused. We just need to get them back, and that starts with a proper diagnosis so that we can fix things. We need to identify what the problem is, and then we need to fix it. So with that, Merry Christmas, everybody, and we'll get to you at the new year. Bye bye.